We will be starting the keynote debate on A View from the South. We've been joined by two more panelists. Dr. James Mwangi, who works for the Kenya Red Cross, where he coordinates healthcare during emergencies. He has already held a very interesting talk on Dadaab yesterday. And
sitting next to me is Tammam Aloudat. He's a doctor from Damascus, has a master's in public health in developing countries, and has long experience with the Red Cross and Red Crescent and, of course, MSF. He's now working with MSF Operational Center in Amsterdam, and he will be joining us now for the keynote discussion. Now, James actually has a little rebuttal or presentation prepared for us, so he'll be starting this off with a few minutes of discussing the more controversial points of the talk, which there were a few, I guess, and afterwards we'll open up the discussion and everybody can ask their questions, and we'll have some more rebuttals on that. So please go ahead and get started.
Okay, good morning to all of you. It's my pleasure to be here again this morning, and I just want to continue with the discussion that my colleague Roy has started this morning, the view from the South, and I hope that I'll be able to take just a few minutes before we embark on the broader discussion with my colleagues here. As I have been introduced, my name is James Mwangi, and I hope most of you were in the session yesterday, so I hope I'm not new anymore to you. I come from Kenya, and Kenya is part of the Horn of Africa, and this is a region that has a high concentration of natural disasters. And the natural disasters that we have are not the kind of the earthquakes that are sudden onset. Over the last 20 or 30 years, we have had disasters that recur in a predictable cycle. And the effects of these disasters are devastating to the communities and to their livelihoods. And I want to draw your attention to two disasters that we deal with on a regular basis. We have food insecurity in East Africa, in the Horn of Africa, mainly driven by droughts. And in 1980s and 1990s, we were seeing droughts recurring in cycles of 10 years, 8 years. In the early years of 2000, then we saw a reduction of this cycle from 10 years to cycles of 5 years. And over the last 5 or 6 years, we have seen this cycle reduce further to cycles of 2 years. And for the period that I've been working in the humanitarian field, the last 7 years, I have dealt with 3 major droughts in Kenya. And these droughts are shortly followed by cycles of flash floods. And you can try to imagine this scenario where on 1 year, we are coming to the donors requesting for humanitarian assistance to bring relief to victims of drought. And the following year, we are going back to the same donors requesting for humanitarian assistance to bring relief to the same victims who were victims of drought but are victims of floods. And when you look at it critically, droughts in Kenya or in the Horn of Africa come as a result of failed rains. And then the cycles of floods, they are as a result of excess water that we do not need. And these are the same communities, yeah? And more often than not, these disasters occur in the same communities. Mainly in the underdeveloped areas of the northern Kenya and the northeastern region, which borders Somalia and also borders Ethiopia and part of Eritrea, which forms then the Horn of Africa. So when these disasters happen, then the communities do not have sufficient time to recoup their losses. Majority of them are nomadic pastoralists, and when droughts come, they lose their livelihoods. And their livelihoods, they are livestock. And they will lose hundreds of livestock per farmer, and then after a short while, then the floods will come, and because of that sudden change of weather, the animals will die again, and then after then a short time, then another droughts come. So the end result is that the communities are left more vulnerable after each and every disaster cycles. Yeah? And I've talked about the fatigue that comes when you go to the same donors requesting for funding to address droughts, and you go back a year later requesting for financing to address floods. When we look at a critical definition of disasters, we talk about disaster, and I want to stress on the fact that in major disasters, the communities that are affected by these disasters are not able to cope with the effect of the disasters without external assistance. And often the disasters occur with impact that the communities cannot be able to cope with the resources that survive the disasters. And in these large-scale disasters, then the international community comes in with humanitarian aid. And in East Africa and in the Horn of Africa, we receive a lot of humanitarian aid, unlike our counterparts in India. And these disasters then provide an opportunity for the international community to participate in humanitarian relief. And I learned yesterday that majority of you who are sitting here are looking at building careers in humanitarian work. And probably in the next few years to come, you will find yourself as a humanitarian worker working in Africa, in sub-Saharan Africa, bringing relief to victims of these calamities. I just want to demonstrate shortly about how the effects of disasters. We have vital resources in a community, and when we have disasters, then we see destruction of resources that cover the vital needs in a community, and we see a sudden increase in the vital needs, because once the resources are destroyed, then the communities become more vulnerable, and the need for humanitarian assistance then comes. The focus of the humanitarian assistance should therefore focus on bridging the gap that is created by the impact of the disaster. Okay? So, and in any disaster, you will see that there are human beings who survive, and there are resources who also survive the impacts of these disasters. So, if the humanitarian aid is not properly coordinated. And in the session yesterday, we saw one of the biggest challenges that humanitarian workers face in the field is about the coordination of humanitarian work out there. So if this humanitarian aid is not properly coordinated, then it will destroy the resources that survive in a humanitarian catastrophe, and this even leads to bigger disasters. As a humanitarian worker, I have dealt with this number of emergencies quite often. And I want just to trigger your mind to think about what happens in a humanitarian situation. Whenever we have a disaster, the disaster mitigation cycle comes in three phases. There is the acute emergency phase, where humanitarian aid comes in. Then after that, then we have the recovery and we have the reconstruction phases of to restore the livelihoods of the communities that are affected. And in most situations, you will find that the objectives of humanitarian aid in the emergency phase of a disaster are often met. Yeah? But how then the humanitarian agencies address the mid to long term or the recovery and the reconstruction phases of disaster, then this is where the focus of us should then be concentrated more. Because as I said, we see these disasters occurring in cycles that are too short for the communities to recover from the effects of previous disasters. And what we have done in the Kenya Red Cross, we have tried to shift our focus to providing aid to the victims of disasters. Why? Because, as I said, this happens in the same communities, and it is frustrating for a humanitarian worker, for example, myself, to go to the same community, and I get my friend Loy, he has lost his family, he has lost his livelihood this year. I bring humanitarian support, and after the emergency, I withdraw. And then after 6-7 months, I go back to the same community, and I find him again, he's a victim of the same disaster. And again, I pump in humanitarian aid, food, shelter, and medical care, and then after a short while, again, I leave. So the focus, and this is the focus that we are trying to approach, to adopt from the Kenya Red Cross while addressing disasters in Kenya, is during planning, we plan for the preparedness, we plan for the immediate humanitarian aid immediately after the disasters, and then we focus a lot of attention to the mid to and long-term assistance of these communities. But the challenge that we often find is that most donors commit resources to emergency humanitarian assistance, okay? And when you apply for these funds to address the mid to long term that would cushion these communities from the effects of disasters, then this funding is not available. So we find ourselves trapped in the same cycle of response and providing humanitarian response year in, year out. And just for those who are focusing on building their careers in humanitarian work, I just prepared a few slides to open up the discussion on how you would approach this. In humanitarian situation, like I said, we have survivors. And the survivors who are local, they are the first humanitarian workers. Often, as a foreign humanitarian worker, as an expatriate, you will arrive in a disaster scene 48 hours or 72 hours after the disaster. And you miss that golden hour in which lives are saved. So it is an important thing to appreciate that in every disaster there are survivors, and these survivors become the first humanitarian workers. And I think we learned some lessons from the disaster in Haiti, where humanitarian workers and humanitarian aid were stuck in the ports for months before they could be able to access the victims of disasters. Why do we need to focus more on supporting local initiatives and local volunteers? One is the fact that these volunteers are better adapted to their environments, and their motivation to engage in humanitarian work is because they are trying to save their own after the disaster. They also do not face some barriers, like the culture, the issue of language. And when I look back, I had a situation where we received foreign expatriates in a remote part of our country as a result of El Nino in 2007. And these expatriates were experts in the medical field. But their expertise was not in tropical medicine. So you would find a doctor who is sitting there. The communities are struggling to line up to be seen by this foreign doctor, but the foreign doctor does not have an idea of tropical medicine. and this doctor cannot communicate directly with the patient. So it has to be, we had to have a series of translators. And the question then you ask yourself is, what message is the patient giving and what message is the doctor receiving? Because we had somebody who would translate from a Somali language to Kiswahili and somebody else to translate from Kiswahili to English. So the message then becomes distorted and the quality of healthcare then gets into question. An important point to appreciate is that humanitarian workers, expatriate staff who come to Africa to provide support, they are not heroes in humanitarian work. They should recognize that they are partners in the business of saving lives, and they are there to provide support. And the moment you get there as an expatriate and you lead from behind, then your mission becomes very successful. And as I've said, they often find obstacles in terms of language, in terms of understanding the local culture and the local practices. So, but when you team up with local volunteers and you support the initiatives that are there in disaster situations, then your work becomes easier. Then we have these expatriates who will come and they see themselves as the experts in the field and they want the thing to go their way. My way, expatriate work does not work. And you will find a lot of opposition and the humanitarian work becomes extremely frustrating. There is also a lot of stress in the field. And you can imagine in Africa, I've talked about natural disasters. We have also had a good share of conflicts. And we can talk about the conflict in Somalia. We can talk about the conflict in South Sudan for a very long time, the genocide in Rwanda, the conflict in northern Uganda. And these are some of the scenes that you find in humanitarian, in conflict situation. Dead bodies and dead bodies everywhere. And probably when you are leaving Europe, the North or the West, to come to Africa, these are not the kind of situations that you expect to be greeted with out there in the field. So it is very important to acknowledge that you are a human being, you are an expert in your field, but there are situations in the field that will become overwhelming, and this can become a source of problems for your mission then and for how you cope with these experiences in your future life. So it is good to appreciate that you are a human being, you have your own limitations, and when you need to see somebody to debrief and to get psychosocial support, it is human enough to do this. And we have seen expatriates come into the field missions and they break down and they become social wrecks because of things that they see in the field. Some of the challenges that you will find yourself facing in field situations, extreme weather. In Africa, you will have temperatures rising as high as 38 to 40 degrees, and you are used to temperatures of 20 degrees and below. It is above today. Then the confusion about time, yeah. In Africa, you are certain that you will see the sunshine every morning, and the hours of the day are 12, and the hours of night are 12, unlike here, yeah. Then you will face isolation from family. Sometimes these missions are long, 3 months, 6 months, in a foreign land. And it can become draining and you feel isolated, and sometimes it leads to social problems, getting into alcoholism, and you get lost in that humanitarian work. So it is not always fancy to get out there in the field, and work is tough out there. Then there are certain limitations in freedom because of issues of security, when there are people out there who will see you as an asset. And yesterday when we were talking about Somalia, we talked about the threat of abduction of expatriate staff, and we have seen this happen. So there are limitations that when you live here, you think about your humanitarian work, then you will go to Masai Mara, but when you get there, you find yourself in Somalia, okay? And then competition in the field, the issue of coordination. Every team of humanitarian workers are flying their flags. We are from Germany, we are from Finland, we are from Norway, and not focusing on the overall mission of providing humanitarian work and providing aid. And then exposure to tropical diseases, examples being malaria and tuberculosis, and we have seen this happen in field situation. And of course, the threats of road accidents and tropical animals. Survival tips. Important thing to appreciate that when you get there, it is in a multicultural environment, and you need to exercise sensitivity in terms of respecting people's cultures, respecting people's norms and traditions. Yeah, and you have to separate your views from the views of those communities there, sometimes in remote areas, sometimes backward cultures, but you have to respect those cultures. Yeah? Not making commitments to local communities. The demands are there, but you need to know how to manage the expectations of the communities. You have come, they will see this is humanitarian aid coming from Germany or from Britain, and they have a lot of expectations. Don't commit that we will do a 40-kilometer pipeline, because that will be a source of problem for you and for your mission in the country. Thank you very much. I'll request that I sit.
Thank you once again for sharing those thoughts with us. We would like to invite Dr. Tammam to make a comment.
Thank you very much. When I thought about this invitation, I couldn't figure out whether I was invited because I work for MSF or because I come from the South. Then I got to think on where do I actually stand on that continuum, if you want. And I have a few comments that actually reflect my indecision about that position. So bear with me for a minute. I think we live controversies when we do humanitarian aid. And the first one is in the very assumption that there's a view from the South that looks at the North. It assumes homogeneity of both that doesn't exist. It's slightly unsettling and slightly unfair, because if we want to see who's telling us about the view from the South, me included, we are the guys who have had the good chances of studying abroad, of speaking English, and of, well, you know, looking like you fairly, wearing clothes like you, and being able to interact with you. And if that's the view from the South, then you should reject it, because the South isn't that. The people we serve aren't the people who speak English and wear suits and can sit here and talk to you. This is a very different one that we should explore. If we accept of the fancy Southerners to represent their people, then why are we too stuck on the Northerners representing the Southerners? We need to accept merits of people rather than putting them in categories that assumes that everybody who lives under a certain gradient are pretty similar. And what North as well? Are NGOs the North now? Do we fit in the same category as, you know, the British government or the German government? Do we do the same? Do we think the same? Do we behave the same? Is there a single request that we would like the North to achieve for us? Or do we just ask them to be engaged and piss off at the same time? The fact is, again, a homogeneity that's unsettling. I've been a volunteer in the Red Crescent in my country, and so did James. And we both have celebrated every year on the 8th of May the birth of a person who's not a Southerner. The birth of Henry Dunant, who is the guy who established the Red Cross and who we are all proud of. And that takes us to where actually humanitarian aid and human rights are, to some extent, versed in Western culture. Mind you, not everybody who's written the Human Rights Charter is a Westerner, but it comes from a certain thread. And I'd hesitate before throwing that out of the window just to fit in a less Western world. The second controversy is that of emergencies. And what emergencies? And we've heard very accurate description of earthquakes and acute emergencies and floods. On the other hand, there is a whole different side to it. MSF works today, the office I sit in works on more than 20 missions, about 80 projects. There is 0 earthquakes in that. There are massive, we receive, just one of the MSF offices, we see 2 million patients a year. Very few of them are victims of earthquakes. I think we need to expand it to see that humanitarian aid is indeed about the acute emergencies, but there is a huge part that isn't. And that doesn't include arriving hours later. That includes, MSF has been in Mweso in North Kivu for 20 years, day in, day out, fighting in, fighting out. The same is South Sudan and same in many other places. Those are also emergencies, admittedly less on the news, but no less difficult in life and limb. And what is the value of us there? If there's one value that actually Dr. Roy has expressed, is that learning. What he had to go through, and many of us had to go through, of discovering what malnutrition does. Now we can learn from one place and take to the other. We can actually establish humanitarian aid as a science that takes evidence and it crosses it from one place to the other and doesn't have to fall in the same mistakes. And this is a good thing because we go out from the charity concept, a Western charity concept, into a scientific one where we are still driven by a humanitarian impulse, but use evidence to apply it rather than the, pretty much late 70s, 80s, white guys on a plane going to Africa. And that contradicts, that comes across also when you compare it to local knowledge. And yes, local knowledge is extremely valuable, but it's not definitive. There are 2 points of views. One that sees the world and is blind to the local knowledge, and one that sees the local and is blind to the rest of the world. And the either-or point of view here doesn't work. Another one is actually that cultural sensitivity. And we've heard it several times today, and I would find it hard to say that I shouldn't or wouldn't be culturally sensitive, but that is conditional. I come from a predominantly Islamic community, and I know for a fact that some of our culture is valuable, is wise, and it has helped us survive as a culture and as people for thousands of years. Some of it isn't. Some of it is discriminatory, unaccepting, and doesn't allow other points of views to come in. And that has to be accepted. And I think that I fear that as foreigners, we are at the risk of sometimes sliding into everything that is done that I don't understand is culture, hence I have to accept it. And that shouldn't be the case, because some of it harms the people that we want to help. And sitting there, MSF has a policy that we provide abortion. It's culturally inappropriate almost anywhere in the world. However, we think that it is versed in our understanding of people's sovereignty over their bodies and their rights to make choices. The fact that we could do it is slightly different, but the fact that we are by definition, culturally insensitive is something we should be proud of on at least this one. The last one I'll talk about is the sustainability. We are humanitarian actors. I wouldn't want my surgeon to do my physical rehabilitation because they don't know how to do it. And a big part of what has made us lose ground is that we thought just by the virtue of us knowing how to do humanitarian aid, we should know how to do rehabilitation and reconstruction and sustainable development, which isn't the case. And I remember as a kid reading a fable about a crow who was jealous and wanted to learn to sing like the canary on the tree. They tried and tried and tried, forgot their voice, and never could sing like the canary. I'll finish by saying that all that doesn't negate in any way that every humanitarian aid worker I know, will always strive to respect our partners, will always seek the local knowledge, will always ask the people we serve if our service is appreciated and acceptable and achieves their expectations. And we will listen to them. And we will try to do no harm, and this is very important. But I still also believe that humanitarian aid workers should strive to do what humanitarian aid workers have always wanted to do, to actually go there and save lives. That should remain the major issue, and that should remain the uncompromising fact. Much else are tools in our way to try to save lives that shouldn't have been lost or shouldn't be lost. Last thing is, I would say, for me at least, and this is a very personal view, I'd rather be a proud pitch black crow who doesn't know how to sing than to be a half-assed canary. Thank you very much.
Thank you very much for your rebuttal here and for bringing up some interesting new points. I think one thing that stood out, an overarching theme, was that all the three of you mentioned a concept of having local care, local resources available to help, not only in emergencies, but for the long-term care. Now, most of us here, we're in Germany right now, we're not from the south, even though it's not as big a problem as you said. Now, I think a lot of us are actually thinking, how can we help enable that? Is it mostly just putting more money in training missions? Is it more of a concept of going there repeatedly, trying to train people, trying to come back, spoil our good surgery results by coming back and doing investigations? How can we actually help train the local population who might be suffering from fatigue if you have a drought or a flooding every 8 months? How do we actually help with that? Maybe we can start with Roy, and maybe you have some thoughts on that.
Thank you, Florian. So personally, I'm of the opinion that emergency care is much harder to provide than routine chronic care. And unless you have provided a reasonable amount of routine care in a country or in a place, suddenly to get in and start providing emergency care is I would say, a little difficult. And so I think though the whole mandate of humanitarian aid is all about acute help, I would think that there has to be a longer term relationship, and I've seen that work much better. That the organizations who've already had a presence there, look at Haiti. I mean, all the organizations who were in Haiti before the earthquake there's a clear difference. You stratify the results, and they have done much better work than the people who came in after the earthquake. And I think that's my only recommendation. I know that acute care is required, but it's just harder to deliver. And I would exercise caution because, again, you need to have enough papers coming out what happened after. And if you don't have that, it's always, we did a great job and we saved lives. Yeah, I agree with that, but maybe we need to have a closer look. That's all.
I think that way to reduce the effects of disasters is exactly what has happened in places that do not suffer the consequences of disaster, namely Europe and North America. There has been a very clear documented move towards poverty reduction, better infrastructure, and hence better health and better survival. And yes, of course, humanitarian aid is a band-aid that tries to mitigate some of the loss of life and limb of emergencies, but will never replace an actual concerted effort towards poverty reduction. That isn't, however, something you want to leave to random NGOs with no overarching plan. OECD has promised 0.7 of their GDP for development. None of that has come true, and have promised many things as a single world that we see much more interaction in, and not much of that came true. The people need to be able to eat, drink, have infrastructure, have medical care on the long term to be able to be resilient enough to resist the effects of disasters.
James, would you like to?
Yeah, just one point regarding some of these chronic disasters. They are predictable. And when they are predictable, there are certain signs that you will read with time that points to a coming emergency. But often, measures are not implemented well in time to prevent these pointers sliding directly into a humanitarian emergency. So if we can focus on how to work on to mitigate, to pick the early warning signs and implement measures that will cushion these communities, then we will prevent this getting into humanitarian emergency. And when you look at the cost of dealing with the humanitarian emergencies against the cost of doing these mitigations and preventing the emergencies, the cost of delivering acute emergency is so enormous, but these resources are not immediately available. Secondly, I just want us to think about how do we deliver humanitarian emergency and at the same time preserve the indigenous knowledge and for example, when you look into 50 years back in Africa, we were having droughts, but we were not having the kind of humanitarian aid that we see today. So how were these communities able to survive those events of those years without the help coming from the north or the help coming from the west? But my thinking is that the way humanitarian aid is delivered today, it destroys the indigenous knowledge, the coping mechanisms that these communities have been able to nurture over the years, and the way we deliver humanitarian aid again is also not sustainable. So I want us to think about those two dimensions: how to mitigate and how to lead the early warning signs, and how to preserve the indigenous knowledge on handling disasters.
Thank you. I think at this point we were hoping to open the floor to questions from the audience.
Good morning. Thank you very much. My name is Martin Quack from Diakonie Katastrophenhilfe, a German humanitarian aid organization from the Protestant Church. Thank you. I have a question concerning two international processes going on since some 2 years. One towards possibly joint standards for humanitarian aid, and one towards kind of a joint certification model based on those standards. Do you see any chances related to those processes that some of the problems that you have described might become less severe in future, especially that humanitarian aid will become more accountable to the people in need? I don't know how far you're familiar with those processes, but whether you are or not, do you see any chances in such a large international process?
Thank you. I think that's one of the solutions, definitely. And just after my talk, I had a number of students saying that we want to come and see what it's all about. And I think that's the process that we need to formalize. You could see in the counters outside that there were so many of these masters in international health, masters in global health being provided by universities. And there is, most of the curriculum is delivered through simulation, tabletop exercises, but there's a whole world out there. The difficulty that we've had is if you have students come over to a conflict area like ours, like I would say India's got a number of areas which are conflicted, but they're protracted conflict. It's not completely violent. It is reasonably safe for students to come in there, but it's not, you can't give a guarantee. Now, how do we get into that model where we are able to take students from here, expose them early to what the real world is, and still make it reasonably safe is the current challenge that I'm facing. But then these joint collaborations definitely is the way forward, And I'm pretty sure that if we have combined courses, then very early in life they would get to see these kind of environments in a reasonably protected environment before going off as aid workers.
I suppose you're talking as well about the efforts like the Sphere project leading to something called the Sphere Handbook, the Humanitarian Charter and Medical Standards in Humanitarian Aid, which has seen 3 versions so far, starting 2004. The absolutely brilliant effort. You need to establish, again, that falls into establishing a science. Going from a gut feeling of what humanitarian aid should be into a scientific approach. However, the Sphere project is, as it claims, minimum standards for humanitarian aid on 5 different issues: water, sanitation, distribution, and medical services. And it puts very simple numbers. I would argue that this is a very, very first step, and by far not enough to apply accountability, because it assumes, again, homogeneity. It assumes, one single population. 15 liters of water per person per day are a very, very different story between Maban in South Sudan or TC in Chad or Jordan in the camp. And that doesn't mean that the effort of aid and the cost implies differ as well. To make 15 liters of water available in Maban is a whole different story from making that available in Jordan. Those are, to some extent, arbitrary, I must admit. It's exactly like the emergency threshold. We say now that an emergency threshold is 1 person dying out of 10,000 people every day. So 1 per 10,000 per day is the acknowledged emergency threshold, and it was calculated by doubling the highest one, which is the Africa one. Again, very arbitrary. We use it because it allows us to compare and contrast our improvement, but it doesn't by far make us really, really accountable. It's interesting. Dr. Reis talked very good about the lack of evidence. What we need to do is start going from there, defining what do we not know, and go and learn it through vigorous research that actually uses research method, evidence-based humanitarian aid to make it easy. Just like what was done with medicine over a few decades, we need to do a similar accelerated process in humanitarian aid.
Would you like to comment or next question?
I think the gold standard in humanitarian work has remained to be the Sphere standards. And when determining the needs, when I was talking, I talked about humanitarian aid filling the gap between that has been created by disasters. But how do we quantify those needs? There are assessments that are done, but is there a standardized way of conducting these assessments? As a Red Cross, we have our own standard way of doing these assessments. I'm sure MSF, they have their own standards. So what does become applicable to the field, then to inform the application of the sphere standards. But I agree, the gold standard has remained the sphere.
Thank you very much for your answers. Are there any more questions?
Hello, my name is Regine Ducos. I'm working for the French School of Public Health, and I first of all want to thank the speakers. Really, it was great insights into the dynamics between expatriates and local communities and the entire relationship that goes on. So I have two questions. One to Dr. Roy. Your presentation about the publication statistics on how few publications are authored, in fact, by researchers from the South, I think was very striking. So I wondered if you would have any recommendations or strategies on how institutions like mine, like schools of public health or research centers, could help to support that. That's the first one. And the second one, I found it quite interesting, in fact, the two descriptions of the expatriates that Dr. Roy and Tammam just presented. One, like motivations of seeing a different country, needing a break, what your nice slide was about, and your ideal on every humanitarian worker is there to do good, and so on. And I think the reality is somewhere in between. The cursor is somewhere in between. Now, I have seen cynical humanitarian workers outside, burnout, stress, security challenges that people weren't psychologically able to cope with. Now, that wasn't the majority of people I saw, but I think this is really there. And this, I have seen it in NGO workers. I have seen it in technical assistant people that come from the World Bank or other. That's not the same type of contract, not the same age group normally, but I have seen it in both. So how do NGOs cope with that, and how do they A, prepare, and B, get the people out when they shouldn't be there anymore? I think there is this issue, and what is the career path for people who shouldn't be in the field anymore because they probably don't have anything to give anymore. So how do they can go back into a different career after that? Thank you.
Excellent questions. I would say the second question, of course, is about the whole charity model, and we're doing God's work, and how can you question God's work? And that's the trouble I've been facing. And every time you criticize to a point, and it obviously upsets a lot of people that now you are criticizing what we are doing in the charity model, or this is God's work that we're doing. Now we have to move on from there, and that's why my focus is on research, and we have to get from this whole action-based thing to at least action-based research. So your first question was absolutely accurate. What we lack in the South is definitely the ability to do good research, because as a doctor, you are supposed to serve. There are just so many patients out there that you are supposed to get out there and start treating people. And if you're doing research, you're wasting your time, or you're not a very good doctor. So that's the thing that we lack. We lack good methodology, and we definitely lack good English writing skills. And I think that is something that we can contribute. In my systematic review, I found that the best papers that we achieved very good levels of evidence was actually collaborative papers. Were collaborative papers written with one partner from the South and one partner from the North. But there are a lot of these papers being written only by the North, and I think that is what we should try to shift. That it's not about Stanford writing about Yemen or Johns Hopkins writing about Rwanda. It should be more of a collaboration, and I think that's what we are going to be able to achieve in the future. And I'm pretty certain that that's the trend we will see in the next 10 years. That there's going to be more solid evidence coming out, and there will automatically be a view from the South showing up in literature.
It's a good question about aid workers. However, I would at least hope that we're starting to get over the classic aid worker image. It doesn't really exist that much anymore, and hopefully will exist much less. And I'm quoting here, if you've seen an Angelina Jolie movie called Beyond Borders, that guy in a cowboy hat and a wrench and a doctor's scalpel doing stuff alone in a camp somewhere in Ethiopia. That isn't the case anymore. We hire people more and more on very strict professional basis. And we do follow sometimes models where people come and go. Some of us have made choices, for good or for bad, to stick to this on full-time basis and do it all the time. But now, rather than bragging about working more or never having a rest or being shot at multiple times or having had malaria 3 times last week, we actually spend time doing our job and making it more balanced with life. But there is a lot of literature that's being done. And the Red Cross, for example, has produced a good amount of literature on managing stress in the field. We have an obligation for managers now to figure that out. Our medical coordinators have an obligation to look out for stress signs in their staff and deal with it, whether expats or local staff, because that's not exclusive to expats. And many people do not go into burnout anymore as they did before. But that's also, I think, personally, that this is a factor of us starting to see ourselves as people who are professionals who are doing their job, rather than, superheroes minus the cap, the cape on our backs. It's more of a profession governed by science and practice and towards more clear aims. And hopefully, if that goes on, we end up with a more mainstreamed way of hiring and sustaining people.
And it is not always on the negative. We have people who have very good experiences from field missions. And the field mission, the foreign expatriate missions are able to consolidate and present technical expertise from diverse fields, assistance that would not ordinarily be there outside of disaster situations. And we have seen people, especially in the Red Cross, I know people who have worked in field missions, in disaster situations, and have built careers of over 30, 40, and 50 years. And I think one of them was a presenter yesterday who is working with ICRC. And they come out of these field missions with very good experiences to share and to document. So it is not always in the negative. The thing is, part of the way to manage these situations in the field is to make sure that you plan short missions. And after every short mission, then you go for psychosocial support, and we ensure that the psychosocial component is an integral part of the humanitarian mission. And this should not only be available to the expatriates, it should also be available to the local volunteers as well. So we would not want to discourage you. It is, and humanitarian work can be fulfilling, because you see results almost immediately. You get into an acute emergency where children are malnourished, and you implement nutrition programs, and within 1 month you see children who are on deathbed running around after 1 month, 1.5 months. And there is nothing as fulfilling for me as a humanitarian worker to see these immediate results.
I think we have a question up here.
My name is Peter Pollack. I have worked almost 40 years in developing countries, 26 years in the World Bank, and I've worked recently with MSF. I'm by training an economist, also a physician. I think I would question this whole model of North-South. I have seen the South moving north, if you think about China, India, Brazil, and I have seen some of the North countries moving south. If you think about how the emergency situation in the US, Katrina, was managed, how the Japanese managed Fukushima, I think there is a blurring of the whole borders between North and South. And I think some of the traditional concepts I hear from you, Dr. Roy, I think may a bit antique. Sorry for the criticism. I think the whole feelings of colonialism, xenophobia, we don't need any aid. I mean, I have worked 16 years on India. I have heard these arguments very often. And I think this is no longer really a driver. This no longer is really true. I think aid workers, if I may say so, or humanitarian workers, need to refocus completely what it is, what they want to do in their lives, in their careers. I think the old models where the North has provided the missionaries and the missionary doctors and so on, all this is over. I think there are areas where the North will still provide specialized medical assistance. I think there are still in India living 40% of the population below the poverty line. A lot of the lower castes, Dr. Roy, you will agree with me, do not get the medical care they would perhaps need. There's a lot of cleft palates, a lot of burn injuries that are not being treated, and where aid workers, physicians have definitely a role to play. There are disasters where India and other developing countries should actually ask for help, but out of this old pride of the fear of colonialism, they do not. I think there has to be a rethinking of the mutual support between North and South. There's nothing wrong, and I guess India has offered help to the US with Katrina, I think. Nothing wrong to hurt the pride of our American friends. I think the second point, this is one point I want to make. The second point, I guess, is if you want to help, you have to have specialized knowledge. You have to have something that makes a difference. If you can deal with burn injuries, cleft palates, things which are not being treated at the same extent in the countries you're going, language skills and all these kind of good things are much less important. I think you don't have to talk that much as a surgeon. You have to select the areas where you can be active. There is the areas where people do not go, people do not move in war situations in Syria, for example. Not too many from the north or the south are too eager to stick their necks out. I just recently came from Syria, and there was some lively fighting there. So I think these are two areas where aid workers, humanitarian aid, will play a role. But the old concepts of aid flows from the north to the south will increasingly dry up. This is not going to be the future. You will have investments, you will have a much more commercial, much more professional relationship. Third point, I have worked a lot with NGOs from the World Bank, and I guess I was sitting on the other side of the table. It's a hell of a job. It's like dealing with a bag of fleas. Each one has their own objectives. Each one has their own desires, their own skills. And to get them lined up and doing something along a certain objective has been extremely frustrating and difficult. I think there I would recommend that NGOs do a little bit of introspective thinking of how they can serve a common objective, even if they have a different clientele at home. Otherwise, it becomes very, very difficult to work with them, very difficult to really take advantage of them. I mean, in a positive sense, they have something to offer. So I think these are the 3 points I want to leave you with. Just take it from 40 plus years of working in developing countries. Thanks.
I'll say one little thing. Dr. Ray mentioned that in Asia, no one will tell you no. In the Middle East, if you hear someone telling you, I completely agree with you, then expect a complete disagreement. But I don't completely disagree with you, but I need to challenge one concept here. The missionary doctor is dead. I don't agree to that, and I don't want to agree to that, because in this very room, there are people who spend their days working on what could hardly be called anything else. Doctors and nurses, both from the north and the south, going around in countries and treating the last pockets of human African trypanosomiasis or sleeping sickness, from one patient to the other. Going, if you have the time, go and Google it. There's an Al Jazeera documentary, 20 minutes worth watching. People will jump on a car, then on a boat, and then they will go and in the middle of the bush will set up laboratories and screen people and treat the last cases. And that is not only a function of failure of health system in countries that still have endemic trypanosomiasis, but it also is a factor of failure of the aid system to provide money and support to eliminating what is admittedly a neglected disease. There are places where, no matter how much we want to professionalize and mainstream and do stuff in meeting rooms, very little will replace the missionary who actually believes that it's worth going and putting themselves in danger and spending enough time in places where even Southerners don't go and treat the last patients of the last disease that still kills people.
I think you perhaps misunderstood. I talked about types like Albert Schweitzer. I didn't talk about religiously financed hospitals. They're getting fewer and fewer. The churches don't have the finances anymore to finance these hospitals. There are very committed people in Africa and other places that work like you described. There's no question about that. But Dr. Roy, can you think you can get a visa in India if I'm a missionary? I just want, you don't have to answer it, but be careful. Not too many missionaries get into these countries. So,
just by missionary, I didn't mean religious missionary. I meant a doctor with a mission, actually.
So, sir, all excellent points there. And firstly, as you said about Katrina, and we had the floods in India at the same time, and we saw the differing responses. And I must say, nobody came out with guns and things like that didn't happen, which actually speaks about the resilience that even James spoke about, which is something that is inherent in communities which have been living with difficulty and in danger. And I think while I want to take everything that is modern and new, I would and not that I have respect for everything that is old, there are certain things which even James pointed out, is that there is an inherent resilience when you're living a life without electricity, a life without, when you don't know where your next meal is coming from. And we don't want to take that away. We don't want to take that away as we give aid. For example, there is no emergency medical service. There are no ambulances in most parts of India. So what happens with a road traffic accident? The next guy stops, picks you up, and takes you. And it's not a system. It's chaotic, but you get to the hospital. Now, you have implemented this half-baked ambulance system, which probably works, probably doesn't work, and then you've taken away the social structure, the social system of helping each other, and you've replaced it with a poorly functioning government system. Perhaps that would end up doing more harm. So before we take away whatever exists and replace them with other structures, we need to have a good thing. That's my first note of caution. Second is, of course, this north and south divide, I totally agree, is vanishing. I hope I'm not going to be giving these talks very often, and it's going to be more of south-to-south collaboration, which I think is the future. Because if I were to work in East Africa, they have conditions very similar to me. And I think I would be able to very easily fit into that culture. So probably it would help a lot of missions that are leaving from the north to pick up at least a bunch of people who are from other parts in the south to go along with them. So it won't be that classic, the classic mission format of everybody from the north going to south. Third, about specialized surgery, point absolutely well taken. If you're going to repair a cleft lip, you have to be a very well-trained surgeon. And it does not matter if you're doing it in tribal India or in rural Africa, you need to be well-trained. My question is going beyond that. My point is, what is the burden of cleft lips and cleft palates that you have cleared with your missions? Now, if missions for cleft lip, cleft palate came into the country and they did 4,000 surgeries, and 4,000 surgeries took care of 50% of the burden of cleft lip children. So there are 8,000 children and 4,000 surgeries were done by the visiting missions. Great job. 50% of the problem done, and next year you come, you will have a cleft lip-free population. But we don't really know what the burden of disease is. What if you came and did 4,000 surgeries and there were actually 4 million children out there with cleft lip and cleft palate? And then you were only handling probably 1% of the load. And my caution is that when you don't know the denominator, it's very easy to say that we are doing this great work until you know the denominator. And then once you know the denominator, maybe you're not so sure. And maybe you'll take 100 years of these missions before you make that country free of cleft lip and cleft palate. So my caution is that if it is the denominator that is known, then probably you need to get into a different model, and there are certain diseases that can be, there are certain maladies that can be sorted with missions, some which will not get sorted with missions. And third and last point is, do not think that NGOs are going to replace the government. Now this is where I put on my government hat, and I say that if a country is going to implement healthcare, it is going to be through the government. The NGOs come in and make a statement. The role of international NGOs and any NGO is to innovate, is to get into that health system, show and demonstrate to the government that this is a better way to do it with your resources. And I think that you are not replacing the government. You cannot replace the government of a million people and 1.2 billion people, because there are just so many good people in this room. And I can tell you, y'all are in a minority. And there are not enough good people around, so let us be, though we want to go and do acute care, I think the real role that NGOs and international NGOs have is to be able to innovate and show that within these resources, there is some remarkable work to be done, and this is a better way to use resources. And I think that is the main role, though it's never been mentioned in NGO forums.
I do want to disagree on one thing. Do we care about the denominator? The government should. The government's job is to distribute resources in an equitable and accessible way. NGOs, does it make it any less valuable that those 4,000 kids, whether the denominator is 8 or 8 million, does it make it any less valuable that they have no cleft lip anymore? We have a surgical project sitting in Ramta across the border from Syria. We've received about 100 patients in the past 4 weeks. Probably every one of them would have died without having received the follow-up surgery, because they got the first surgery inside by field hospitals. This is a conflict of 100,000 dead, probably triple that injured, probably most of the dead didn't die immediately, suffered their injuries. Does it make it any less valuable to have saved the lives of 80 persons who would have died otherwise? And this is the particular point where you think differently if you are a humanitarian organization or a government or developmental one. When I worked in the Red Cross and had a part developmental mentality, I thought about denominators, and I think about them much less now. I think about outcomes. I think about persons who will actually survive. But the other point is absolutely right. That will be less valuable if it doesn't get coupled with a strong, decisive voice that carries the voice of those patients and deliver it to people who could hear it. Today, when I left Jordan, that surgical project had 7 kids with amputations. Those are children who will probably not be able to work, probably will become beggars, probably will have a very difficult life. And the next step we have a responsibility for is carry their voice and tell people about them, but about the potentially thousands of others that need rehabilitation, prosthetics, and the ability to reintegrate in normal life. So yes, we do need to make a statement. But I will have to struggle with not doing those 60 because the denominator is 60,000.
Thank you. Are there any more questions now? Is anyone over here?
Yeah, my name is Frank. I'm from MSF here in Berlin, and of course, I also want to ask a question with regards to, thanks first for the very nice and different views as they came across, and it was really challenging also and very provocative to some extent, I understand. But what I'm missing is a bit coming back into the question of the access somehow. The whole thematic of this somehow Congress is going into access and how to improve it. And I understood also, well, I see the controversy in some of the approaches somehow. Long-term developmental approaches needed and innovative approaches coming maybe as an add-on from those organizations from the outside to support somehow developmental initiatives of governments, etc. But that leads somehow out of sight the politicization of the overall context and what humanitarian work, and MSF is mainly or particularly looking into this conflicts, protracted crisis, neglect, deliberate neglect of particular populations who are not receiving what should be obligation of the government. So I feel there is definitely a point which somehow didn't get into this discussion, because governments are not always a solution to the problem, but often they are part of the problem. So how do we, as humanitarian workers, start to try to overcome this? If I look at Pakistan, for instance, we had this earthquake 4 weeks ago. MSF tried from the first hours to get towards those places to really go, and we had teams on the ground. We were not far from them. 4 weeks after, we have to go public and tell people, no, the government just didn't allow us. So would it have made a difference? We don't know, because of course military, yes, they had put some aid in these places, but on the other hand, we usually know that there is a certain, let's say, bias towards certain groups. They are not receiving necessarily all the same care to the same amount, to the same extent. So how do we deal with these situations?
Now, I'm going to respond with my government hat. The thing that is bonding everybody in this room is everybody is non-government. Okay, there is nothing similar between a lot of groups that are functioning here. They all have their individual mandates, their philosophies, where they're coming from. But the one common thing that you have a common devil, and that's the government. It's a great way to bond. But I'm not going to try and challenge that. All I'm saying is that since I work for the government and I work for NGOs, all I can say is that the government have got good people also, and they are doing. They have their limitations, or they don't have the flexibility of an NGO. And that's when I love to put on my NGO hat, and you said that the hat is no longer important. I don't know what to do with that. Angelina Jolie won't accept me in the movie.
That's a cowboy hat.
So the cowboy hat allows you to do things that the government, you would not be able to do in the government, through the government. Now, I think it would be just painting the government as the devil, and the government is this. I think I have compared my work being with the government and with 4 other NGOs. And it's very inspiring, the NGO work, but in terms of volumes and in terms of delivery, in terms of having a system, a PDS, a public distribution system, an implementation, the line departments, we're able to do things which definitely at an NGO level, you're not going to be able to do. So I think there is a role for the government, even if it is weak, even if it's, there is a structure there which I think cannot be ignored. And I agree the flexibility that you have in an NGO is remarkable. And that's why it's so nice to work in an NGO. It's so inspiring and it's so boring to be working with the government. But that's the way it is. I think there is a role, and I think this whole gongo, this government organization, non-government organization kind of deals are the ones which are going to, because there has to be mutual respect between the two. Because otherwise it's this maverick NGO, kind of organizations who are going to go and do that. And though MSF, kind of signifies that kind of thing. It's really inspiring to meet people from the MSF who are able to really go to the deep interiors and do stuff. But I think it's not a system. It's not necessarily a system which is going to solve the problems. We'll have to take the government along, or the government and vice versa.
I don't think the government should be absolutely ignored or bashed. That's not the point. And I don't disagree in any way that the government is probably composed of mostly good people. If I wanted to be slightly cynical, I'd love governments to do everything they can as long as they don't get in our way. But that's not how things go. And that is a joke, actually. I don't mean it. But I mean, governments are not an aid body. Governments are also political, military, and administrative complexes. And those do not go together all the time. And we need to know who to talk to and how to talk to. If we thought that the government is insignificant, we wouldn't have bothered that much trying to talk and convince. I think we know how significant it is. But we want to still live on that edge where we endorse what's good and are able to criticize what's bad. And there's a very good example from MSF's experience. We work extensively in Myanmar, one of the interesting governments of this world. And we do have more than 20,000 HIV patients, which we are treating day in, day out. And if it wasn't for the government facilitation, we wouldn't have been able to do that. And we also work in Rakhine, in 2 of Rakhine states, where there is a conflict between Rakhine and Rohingya populations. And the position of the government, the same government, on the 2 things is very different, to the extent that we have to take 2 very different positions towards the government on that. So it's interesting. The government is a much bigger and much more multi-sectoral and multi-interest machine than we could be or could cope with in some cases.
Thank you. I think we have a question from up there.
My experience is largely from Yemen, where there's of course also a huge humanitarian crisis. And to address your point, I find this very, very important. First of all, many INGOs use the government, but in a different way. In Yemen, there's a very limited amount of WASH experts, of whatever experts. They are usually employed by the government. And what happens is that the INGOs hire these government employees. They stay away from their governmental offices, and they get like 10 times the payment they get from the government. So actually, they are not strengthening the government, they are weakening the government. So that's comment number 1. And that happens with MSF, with CARE, with all the big INGOs, because the market for specialists in Yemen is like almost 0. There's also huge competition in salaries. There is no ethic code what fair salaries would be to such experts. It's completely corrupted, to use this strong word. The second point, very important, I really liked your comment. In our organization, Vision Hope, we see us as advocates for the community-based organizations to link them with the government. So on purpose, we do, for example, German government-funded projects where we have as a precondition that the governmental authorities, like the General Authority for Rural Water Supply and Sanitation, and local NGOs are both parts. So we see ourselves as a linkage between the local community-based organizations, which we build up and strengthen, and the government. And as you said, there are good guys on both sides.
I think you also had a question over here.
Yeah, thank you. Hi, my name is Ilya. I work for MSF Denmark, and I do not have a long and vast experience in working in this field, but I have a question to the panel. First of all, I would like to agree a lot with you, Tammam, about you cannot come into this line of work and just think that good intentions are enough. There have to be evidence, and you have to be good at what you're doing, obviously. But coming into this line of work, you're doing it of good intentions, I guess, because you have a will and a need to mitigate suffering in some sort. And that got me thinking a little bit about the North-South divide as well, because when I first heard of it, I got a bit tired of it and a bit annoyed with it, because it kind of reproduces the caricaturical image of the humanitarian aid work that you were talking about, Roy. And that got me a little bit annoyed as well, because I would like to, coming into this line of work, I would like to be judged by the content of my character and my actions and not by my nationality, basically. But then my question would be then, is there a way out of the North-South divide, or do we need it to be able to keep doing the points that Roy and James did about how we could be more accurate and better at what we're doing?
I agree with you. On the offensive side of being caricatured as a jokingly someone who doesn't know anything and just jumps in because they are Westerners and do whatever they can and probably mess up more than they repair. I don't feel like that, and 15 years later I still feel the same buzz in my stomach, let's call it, when I go out into a mission in the field the same way I did on my first mission. I'm a different person today, but that's beside the point. Our business, whether we are international humanitarian workers or volunteers in a national society in underground, is driven by very similar ones. And I've started as a volunteer and ended wherever I will end. The point is, I think we need, if we look at ourselves as people of common cause and interest, some of that goes away, because probably the other person, the southerner who receives you as an expat from Denmark, are slightly pissed about you leaving your safe home and good life and coming to, do something they probably don't think you can do as well as they do. I think there is a point which is the common cause. We need to actually trust each other. We need to be able to understand, and that's a very common thing. When you as an MSF worker and our colleagues in the field who have worked for us long enough, go there aren't the boundaries. The boundaries are in meeting rooms and conference rooms. The boundaries do not exist when you share the same car on the same dangerous route and share the same outcome potentially. The other thing is, I think the image of a classic white mission or Northern European mission isn't the case anymore. I don't know of any international NGO office that consists of Northern Europeans exclusively. And that hasn't happened by design. We didn't do like positive discrimination and insert slightly darker people in our offices. That has happened because the cause we work in and the way we behave in it and the values that carries it have allowed for a generation, including myself, of people who do not come from Northern Europe, to adopt that and go and do it somewhere else, to learn from it and do it from somewhere else. I might have less trouble than you, being slightly darker and less blonde, in asserting myself as a legitimate, not Northerner, but I probably carry the same values you do, and I think that is important to show and emphasize.
Thank you. I think we have one more question up there.
Thank you. I'm Caroline from MSF. I have a few comments. On the state role, I think it's far too simplistic to say that where actually all NGOs are against the government. At least in MSF, we have had the entire spectrum of relationship with the government. It could have been bad relation, very good relation, cooperation, collaboration, whatever, but we're definitely not against the government unless, as Tammam said earlier, there's a point where we actually need to make a statement, and that's something that we feel, at least as MSF, that sometimes we can have this role of témoigner or whatever the name is now. But it's so I wouldn't go into this. You know, you have like the bunch of NGOs and then the governments, and we cannot work together. The second thing I wanted to say was on. We conducted a study on perception and to see how people were actually perceiving humanitarian action in where MSF was working. And it's so far from being homogeneous that it's even just the title, A View from the South, doesn't make sense. I mean, it's we asked 7,000 people what did they think about humanitarian principles. We got 7,000 different answers, including within MSF, and that was one of the most interesting results. So it's really on a case-by-case basis. Just to give an example, Palestine today, and it's going back to the access question that Frank raised again. In the Gaza Strip, people are extremely happy to have access to healthcare that is being provided by an NGO that can actually provide care to people that are not Hamas members. And in the West Bank, people are happy to have access to healthcare. Hamas members are happy to have access to healthcare that they cannot have or couldn't have few years ago in the Palestinian Authority hospitals. So in that sense, there was something that was extremely interesting to see that sometimes foreign medical care was perceived as a safe place where everybody could have access to care as well. So it's, again, not falling into the homogeneous thing. To talk about the common values, because it was discussed several times, before being humanitarian workers, people are actually citizens, and they do have responsibilities in their own countries. They could be engaged in Berlin, in Geneva, everywhere. I mean, especially now with the migrants, you have migrants absolutely everywhere. So if you want to get involved, that's also something that you could do. And finally, just to make a comment on what Tammam said earlier about his kid, and just for fun, I mean, I was used as a woman alibi sometimes on panel or on as the Southern alibi because of my family name. So we're always the foreigner of someone at some point. So it's again, not homogeneous. Voilà. Thank you.
Thank you very much for those comments. I think we'll take one last quick question. Is that okay?
Thank you, Caroline. And all your points are well taken. Obviously, we're moving from caricaturing the government and caricaturing the NGOs to the argument of non-homogeneity. My point is, I am a young humanitarian worker. I've come to this conference, and every time I raise a point and they say, oh, this is not homogeneous. Okay, so now what do I do next? What does a young humanitarian worker do next? I mean, we're not making it any easier for the young chap who says, I am going to change the world tomorrow. Tell me what to do. Well, you do this, things might go wrong, and you try and operate, things might get worse, just so. So while I want to share my anxieties with you, I am absolutely certain, after being in this business, not as long as you, sir, but for a shorter time, I am absolutely sure these are the people who are going to change the world tomorrow. And we need to have some amount of clarity. And that clarity is going to come only when we stop taking individual cases and individual anecdotes though anecdotes really connect you with the people and the problem, but you need to have numbers out there. We need to have numbers. We need to have a science coming in. And MSF, I think I've read some of the papers by Ronnie Zakaria, and this is all coming out. Red Cross makes the best reports for what happens on the field, but they are not peer-reviewed. They're not peer-reviewed, and we need to have more and more MSF reports and Red Cross reports, which are not internal documents, but which are available to the wider community of humanitarian workers. Second, we need to have numbers, so we know what we are dealing with. Because if you say, but I saved that man's life, and that is 100% statistics for that person whose life was saved, it's the end of the story. I mean, there is no argument. There's no argument. But then what about the 100,000 who died? And essentially my argument is, I know there is a value to doing one thing for one person, but there is also a value to saying, okay, so how much of the problem have we really solved? Otherwise, you're going to come back 2 years later and say, oh, Syria, everything is the same, nothing has happened, because you have to take the bottom line. What is the larger denominator, whether you like it or not? Because that's what is going to constitute whether you actually solved a part of the problem. Are you a part of the problem, or are you a part of the solution? That's my defense.
Really need to improve, especially in MSF. But on the world is not. I mean, I can understand that it's not helpful to tell them, people be careful, the world is not homogeneous, but it's true. And that's the reality they're going to face. And they're going to have to face that when they negotiate with any non-state actor they face, with any government, with the community, with everyone. And it's what they bring that would make a difference, not if they arrive with, okay, so government is bad, NGO is good, white is good, black is good. It's not going to work. So it's, at least they know the reality, and then they'll have to deal with it. And that's when we arrive to what James pointed out, stress and burnout and everything. But at the same time, that's part of the fun.
I think we'll give Roy one last chance to say goodbye, and that'll be the end, because unfortunately we're running very low on time.
Yeah. No, I'm being saved by the bell, so I'm not going to...
Okay. Well, we thank you very much for your participation today. Thanks to all three of you, and thank you for the good questions from the audience.